back on. Thank you. So when we look at it from a surgical perspective, and in these images, the superior vena cava is going to be to the right of the screen, the inferior vena cava to the left, and we're looking through left atrium itself. In addition to the mitral valve itself, we have to be aware for the adjacent anatomy, that of the aortic valve, and particularly the non-coronary left coronary cusps, the circumflex artery, the coronary sinus, and a conduction system. And then when we're talking about the valve itself is not uniform. There's this is an image above of the anterior leaflet of the mitral valve. The smooth zone is the surface of the valve, but the rough zone is the coaptation between the anterior posterior leaflet, and the dashed line is representing the coaptation line, to which will become important when we talk about neocords. And as you see the image above, cords can attach themselves to the edge of the leaflet, but as you see below, other cords and struts, which are heavier cords, can attach to the middle of the leaflet itself and the coaptation zone. So it's quite important when we do repairs to understand the differences between those two entities. So both papillary muscles give cords to both the anterior and posterior leaflets. Cords do not cross the midline. So it's very important to understand the normal anatomy of a valve when we're doing both valve repairs and differentiating different kinds of cords and the location of the papillary muscles. Now, as you know, the shape of the mitral valve annulus is not flat, but actually looks like a saddle. So both the A2 and P2 segments of the valve are much taller. That leads to much better coaptation and a larger surface area by having a shape of a saddle rather than a flat shape. But also associated with this physiological mechanism is there are differential stresses where the stresses on P2 and A2 are particularly much higher. And that explains why particularly P2 and A2 are the areas where we see the highest level of pathology. So when we repair the valves, we have to take this under consideration. Now, again, as we described earlier, Dr. Carpentier was emphasizing a more standardized nomenclature and the importance of defining precise mechanisms of mitral regurgitation. So it's not enough when we read reports of echocardiography to talk about the severity of the mitral regurgitation, but to talk about pathology. And in his mechanism, first of all, from nomenclature, we're naming the segments of the leaflets, the anterior and posterior, from lateral to medial as segments 1, 2, and 3. The commissures, I think those are complicated terms, but lateral and medial commissures. And so type 1 mitral regurgitation is related to annular dilatation. Type 2 is related to excessive leaflet motion. Type 3A and B are restricted leaflet motion, where typically 3A is rheumatic disease, 3B is diastolic leaflet motion, which is more related to cardiomyopathy. So it's very important to be as descriptive as possible in your reports, so we as surgeons can be more precise in repairing it. So when we get to the operating room, it's very important to assess the valves very systematically and not just focus on areas of pathology, because by focusing just on the area of pathology, you may miss very important areas that are significant to get a good repair. So we do a very systematic approach where we look at the leaflets themselves, both leaflets, regardless of pathology. We're assessing integrity, we're assessing pliability of the leaflet, the thickness, we're assessing the motion, we're assessing the size of the annulus, symmetry or asymmetry, and calcification. We'll talk about that in a moment. Cords, when we talk about cords, are they elongated? What's the reference? What's a normal cord? So we can compare and then shape therapies related to that. What about the papillary muscles? Are they displaced? Because again, we can adjust those. Clot in left atrial appendage, PFOs and atrial septal defects, and of course, the shape and function of the left ventricle. So as we look at mitral regurgitation, and we look at, for example, the presence of mitral regurgitation with congestive failure, the prognosis for this, even with excellent medical therapy, is extremely poor. So this is data that was developed and assessed at the Mayo Clinic by Serrano, and several of his colleagues. So the survival with medical therapy and without an intervention at 5 years is 40%, and at 10 years, it's 20%. So it's dismal. It's the same survival of somebody with a very advanced malignancy. And the survival is worse with advanced age and New York Heart Association class and lower ejection fraction. So it doesn't mean that therapy would not correct this. There is a survival advantage for intervention and surgical therapy, but the mortality is much higher and the long-term benefit is less. So this led to an assessment by the same Mayo Group to decide whether or not patients would benefit from earlier therapy, meaning once you make diagnosis of symptomatic mitral regurgitation to send them to treatment, rather than delayed therapy of patients given a trial of medical therapy and see what the outcomes are. And if you look at those, the databases and the outcomes from those, there was a very significant reduction with earlier therapy in 10-year mortality, a reduction of about 50%, a hazard ratio of 0.4, and even a more dramatic reduction in congestive heart failure and atrial fibrillation of about 70%, a hazard ratio of 0.3. So that led to the idea of treating people earlier in the course of disease. We don't wait for symptoms or LV dilatation or dysfunction, but the idea is to treat the patient at some time after the onset of symptoms or even before the onset of symptoms to avoid the long-term complications of progressive dilatation and heart weakness that ensue, because this is a progressive condition. So if we look at the newer guidelines for even asymptomatic severe mitral regurgitation, and the European and American guidelines differ somewhat, we understand now that there's more importance given to exercise-induced pulmonary hypertension, to new onset atrial fibrillation, and to left atrial and ventricular dilatation. And those now have a 2A designation if one can do the repair with a high incidence of success greater than 95% and with a very low mortality at less than 1%. So the newest guidelines that were authored by our colleague, the first author is Catherine Otto, the 2020 guidelines. The 2A recommendations to treat asymptomatic patients is conditional. It's predicated on both outcomes and experience. So again, experience meaning at least 25 mitral valve repairs per year per surgeon or 50%, and repair rates with less than mild MR of greater than 95% and a mortality of less than 1%. But if you look at the extensive, even current databases, the incidence of mitral valve repairs until very recently have not really changed very much. In the gray bars, you see that over the course of a decade, if you look at all etiologies, not just simple mitral regurgitation etiologies, the repairs are roughly about 40%. But you could see there in the red bars that if you're going to get a replacement, the valve replacement is going to be done with a bioprosthetic valve. So that's pretty consistent across all databases, and this is the data from the United States. The last couple of years have shown an increase in the incidence of mitral regurgitation. But if you look at mitral regurgitation rates, if you look at all pathologies, the incidence is more modest than we would think. And most pathologies that are treated are posterior leaflet prolapse, where the repair rates should be almost 100%. And currently, 66 to 88% of patients are repaired, and the repair rates are relatively flat and haven't changed until perhaps the last 5 years. So it's interesting that the repair rates vary tremendously and experience varies tremendously among surgeons in the United States. This is a paper by Dr. Chikwi. This was from Sinai when she worked in New York, looking at the New York State database. And it shows you that in New York State, there are 40 cardiac surgical sites, and there are about 200 surgeons. And if you and you see the variability in volumes and repair rates. And so if you look at the very low volume centers, some of them have very high repair rates because it's by intention to treat. You may not repair, you may only do 5 really easy cases and repair all of them. So if you look at what it would mean to apply the guidelines of the American Heart Association and most recent guidelines of experience of 25 more repairs per year and a success rate of more than 95%. There are only going to be 4 surgeons in 2 centers in the state that reach those standards. And again, just for the United States in general, the median number of mitral valve repairs per surgeon is in the order of 5 to 12 per year, and per center 23% per year. And we know that very low volume centers have a substantially higher mortality in comparison to very high volume centers. The mortality ratio for low volume centers is 50% higher than that of high volume centers, and the repair rates are 40% less. So in 2021, a group of cardiologists and surgeons created the Mitral Foundation to apply those guidelines nationally. So to receive a designation as a referral site of excellence using the ACC-AHA guidelines, you have to formally submit your information for site and outcomes and be willing to be audited. And we, UW as a team, certified in 2022 and again in 2023 based on our volumes. And to date, there are only 26 such centers in the United States. If I do the math in the United States, we're going to probably reach 50 to 75 centers that have those volumes, and those are catching up. So we know that if we look at survival, and if you are able to repair the valve, that's the dark line, the outcomes, the long-term outcomes are similar to patients without mitral regurgitation if the repair is successful and the residual degree of mitral regurgitation is less than mild. And if we replace the valve, the survival is much less. So again, when we compare repair to replacements, not only is there improvement in long-term outcomes, but there's also an improvement in function. Patients who undergo repairs have a lower risk of thromboembolism, of infection. They do not require long-term anticoagulation. I'll show you that the repairs are quite durable, with a possible exception perhaps of very elderly patients or those with ischemic MR. So why is mitral valve repair still an art? Why is it not done everywhere? Where I think that, again, this is my impression, it results from incomplete preoperative or intraoperative assessments of not just the obvious pathology, but also other concurrent pathologies. So those other pathologies perhaps are not addressed. And again, one has to accept the fact from a patient to patient, the tissue characteristics and the tissue abnormalities and repairs have to be quite different. So multiple strategies need to be performed to obtain an ideal repair. So what we call a tailored approach, which is multiple techniques being applied to every patient, is essential to treat complex mitral regurgitation pathology more than just P2 prolapse. And they require sequential application of multiple techniques, repetitive intraoperative testing, because there's sometimes a discordance between what we think is physiologically important and what is physiologically important. And the goal is to have hopefully just trace mitral regurgitation or none and no mitral stenosis whatsoever. So again, we're going to talk about the basic valve techniques in a moment, but the key when we think about all those repairs is to really think about long-term therapies in the life of a patient, a lifelong therapy, and to keep in mind future reinterventions, including transcatheter therapies. So the most basic repair, and I just wanted to go with this group, and I know there's mostly cardiologists in this group, is to talk about repair techniques themselves and how they apply. This is the basic foundational repair that every surgeon that was trained in this decade should be able to do. Typically, this is the most common pathology, presenting itself with posterior leaflet prolapse, in this case flail. We would resect that segment, put the leaflet together, and reconstitute the leaflet. So we resect as much of a third of the leaflet to normal chords that are normal consistency and length. If there is excessive leaflet height of the posterior leaflet, we can reduce the height of the leaflet. It's called a sliding plasty. We would then size the anterior leaflet to the rough zone and select an appropriately sized annuloplasty ring, which basically the measurement is commissure to commissure in anterior leaflet surface area. and then complete the repair. We want to avoid over resection, so we spare leaflet a surface area. We can actually augment even for posterior leaflet pathology and use neocords. And we want to avoid overcorrection with an annuloplasty that can lead to LVOT obstruction or SAM or mitral stenosis. So the idea of the tailored repair, if you look at it, and this is data from Dr. McCarthy from Northwestern University, it's a series of over 1,000 patients. We want to end up with a anterior posterior A2P2 height ratio of 2 to 1 and a coaptation length of 6 to 10 millimeters, because that length of the coaptation is related to the durability of the repair. And if we're able to achieve that, and he was able to achieve that in the vast majority of patients, and if you look at his data over a 10-year course, the freedom from moderate to severe mitral regurgitation and intervention exceeds 98%. So this is a very durable, reproducible approach to the posterior leaflet. Of course, one can do other things to the posterior leaflet. You can fold it on itself to decrease the height. That's called a folding plasty. And in the commissures, you can attach either place neocords. We're going to have to do this case this morning, or attach the A3, P3 segment in this particular area, edge-to-edge repairs, to obtain a more competent valve. And if you have a very large surface area of the valve with annular dilatation, that can be done very effectively without ending up with some stenosis. But also there is an evolving role for augmenting the leaflet, not just resecting it. So one can do this, for example, for chronic perforations, or in some patients with perhaps 3B pathology, where there's retraction of the posterior leaflet to create more normal physiological surface areas and more coaptation. The anterior leaflet repairs are much more complicated, and that was sort of the holy grail of cardiac surgical mitral repairs 15 years ago. So the initial repairs were, we understand that you can only resect a very limited part of the anterior leaflet, maybe 1/5 of the anterior leaflet. And originally, in order to replace, for example, anterior leaflet ruptured cords, you would do what's called a chordal transfer. You would take cords from the posterior aspect of the valve and move them to the anterior aspect of the valve with a bit of posterior leaflet, because then you know those cords are the appropriate length, and then repair the posterior leaflet, because we can remove a much more significant segment of that without any significant consequence. We'll talk about the edge-to-edge repairs in a moment. Those are secondary repairs. But basically, the new approach to anterior leaflet pathology is neocords, which are made from Gore-Tex material, which has very much the same physiological performance as native cords, and attach them to the appropriate papillary muscles. Usually we add 2 to 6 cords when we do repair them. And the complicated area that had to be solved is the length of the cord. And not only that, but the length of the cord when the ventricle is full, because when we're assessing them intraoperatively, we have a still heart that is empty. So again, we're trying to attach the cord to the coaptation line to create that physiological consequence and closure mechanisms. And of course, always we add an annuloplasty ring, and I will talk about the importance for that in a moment. So this image, again, reinforces the fact that when you look at cords, and this is an image of showing a natural cord, an artificial cord. If you look at them many years later, you can't tell the difference from the artificial and native cord. And it's really critical, again, and very important to emphasize the importance of annuloplasty rings. So those are flexible titanium rings that we sew into the mitral valve annulus. It maintains the shape and the dynamics of the mitral valve annulus, the saddle shape. It allows for a symmetrical reduction of the posterior leaflet, but more importantly, it distributes the tension of the repair itself and allows for long-term success and durability. So, and now in the current era of catheter-based therapies, it allows for an anchor to future therapy. So we talked about the edge-to-edge repair. This was developed by a surgeon by the name of Alfieri in Milan, Italy. And the idea was that you can attach the anterior and posterior leaflets together with a suture. That is, to me, a secondary repair. It's like everything else. I think it's familiarity, willingness to try a repair, because again, if you fail, then you have to then subsequently repair it. We will never leave the operating room with more than mild MR. So there was very little incentive, particularly if patients, from a outcome perspective, again, it's intention to treat people with complex pathologies. And the assumption was that the outcome would be similar. And, as I showed you, I'm hoping and that I'm trying to convince you that it isn't. So I'll come back to that in a moment, Jim. Sorry. So again, the edge-to-edge repair from our perspective is really great for paracommissural pathology, but it's not a physiological repair. So there are some consequences, particularly if you have to do an intervention later on. If you asked me a couple of months ago, that would preclude all transcatheter valve therapies. But just a couple of months ago, Dr. McCabe and I did a case where he actually removed mitral clips and then did an intervention, or actually have an ability with an electrified wire to cut through the edge-to-edge repair. But that said, to me, this is a secondary repair, and you're trading off some degree of mitral stenosis for mitral regurgitation. And it is the basis of the edge-to-edge, the transcatheter edge-to-edge repair. But if you look at Dr. Alfieri's data, and 5% of his patients that he did not get annuloplasty rings. And this is a set of 50 patients that he was following. And if you look at long-term outcome without an annuloplasty ring, the incidence of recurrent mitral regurgitation that's severe, more than 3+, or need for reintervention is about 50%. So at least in the surgical data, results without an annuloplasty ring are not satisfactory. It'd be interesting to follow and see whether or not the same trends are seen with mitral clip therapy. So the new kid on the block that we're trying to really get around is this mitral annular calcification. It's increasingly common or increasingly recognized because now every single patient is going to get a CAT scan prior to surgery. And we know that it's much more common in patients with mitral stenosis, but we also see it in patients with mitral regurgitation. And we know that those patients, they not only is the technical aspect of doing the surgery worse, and more complex, but the prognosis is significantly worse, and they have much higher incidence of comorbidities. So tackling this is a real complicated issue, both for transcatheter valve therapies and for surgery. So the previous approach to this was a mechanical debridement. You see the instrument on the left, that's called a rongeur. It's actually an instrument used for bone surgery. And the current instrument that we use is an ultrasonic device called the CUSA device. But when you remove the calcium from the AV groove, you're essentially causing an AV separation. And sometimes you don't see it. It can be just tiny micro holes that even if you patch them with pericardium, there could be a perforation when the heart starts to beat again because you're creating a weakness in the back part of the heart. So this is a patient of ours that had severe MAC that went to the operating room. This is the degree of calcium that we took out from, not the leaflet, but from the annulus. And look at the CUSA device. That's not a watermelon on the side there, but actually saline that's tinged with blood from the suctioning part of the device. But all the yellow tan tissue on the bottom is small areas of calcification. So you can imagine that even though we irrigate and suction them all out, if those escape our surgical field, they would cause embolization. So again, patients with mitral annular calcification have a much higher incidence of strokes, AV disruptions, complications, and death. So where are we now with surgical repair techniques? We know that in high volume centers, like the data from the left, the incidence of mitral valve repairs now are very close to and exceed 95% for all pathologies. This is a series that was published a couple of years ago from CMS data by Dr. Badwar of 2,400 surgeons, 1,000 hospitals, showing that there is significant inflection at doing more than 35 patients a year per hospital and 35 per surgeon, 75 per hospital. But we can say now that valve repair techniques are safe. They're with a mortality of less than 1%. They're reproducible. I'll show you our repair rates in a moment, and more than 90% of all valve pathologies could be repaired. They're durable. We showed you data that they're going to be free from reintervention in the majority of people, and the average length of stay is about 4 to 5 days. So at the University of Washington, our repair rates, and we just looked at them for the last 5 years, are 98.9%. This is all pathologies. 2/3 of our repairs are so-called radical repairs, not just posterior leaflet prolapse. Those just represent 1/3 of all our patients. All patients have less than mild MR. We have zero mortality since I've been here now 25. This is my 25th year. Short length of stay, and we talked about the concomitant procedures. So far so good, but we have room to improve. Again, going to Jim's point of view, to try to repair even more valves, including patients, for example, with endocarditis. And again, we have to also have the ability to treat other associated pathologies, particularly atrial fibrillation and the left atrial appendage and tricuspid regurgitation. And you know, those are quite common. So they can be done with no additional surgical risk. They take a little bit more time, but not significantly. So again, 30% of MR patients have atrial fibrillation. We can treat those with ablations, left atrial appendage clipping. There is some discussion of whether or not all patients over the age of 65 should have left atrial appendage clip. Easy to do, takes about a minute to do, and may decrease long-term stroke rates. And of course, tricuspid pathology, it's interesting that in the operating room, we see it much more commonly than we thought. And again, we would approach it and treat it if there's more than moderate mitral regurgitation or the annulus is enlarged, because we know that treating mitral valve pathology would not necessarily eliminate a tricuspid regurgitation. And so we would typically put a tricuspid ring at the same time, again, with no added risk. So going back to your questions of incisions, it's very common to spend half the time with a patient talking about incisions. I think that it's important to put in perspective, a median sternotomy is very well tolerated. We can do all the adjunctive procedures that we need to, including ablations and so forth. So what are the approach for non-sternotomy incisions? I don't like the term minimally invasive because they're not necessarily minimally invasive. They're just smaller incisions or alternative to sternotomy. So you can do a thoracotomy approach, a mini thoracotomy approach. You're going through muscle. It's actually quite painful. Or you can do a robotic approach with 5 different ports of 1 inch each, which also can be done. But remember that then by definition, it requires peripheral bypass, and that's more hazardous in older people because you can have embolization, right? So is the term correct? Is it truly minimally invasive? I'll show you some data in a moment. And are you able to do all those other procedures, such as a maze and a tricuspid valve, through the same approach with equal results? So if you look at the data, there is a very significant clinical bias that younger people with more simpler pathology and thinner people would get minimally invasive surgery. And there are very few randomized controlled trials, right? You need huge numbers. You're talking about a success rate of 95% and a mortality of 1%, right? But there are meta-analysis and there are small randomized trials. And what we can say now is in experienced hands, the repairs are quite similar. There is no significant difference in mortality and morbidity for minimally invasive surgery. There is no question that bypass times and cross-clamp times are longer for non-sternotomy approaches. Sternotomy, usually the patients have more complicated repairs, and you see an early non-significant improvement in quality of life that has gone by 3 months. So there might be an early benefit, and perhaps subsets of population have yet to identify. So, but we're now at a dawn of a new era of transcatheter mitral valve repair options, and those are evolving. They're promising. They're indicated for high risk or inoperable patients, but we need to still establish a long-term durability. Most of the reported data is on the order of 3 to 5 years. And we need to think through whether or not they impact surgical options. So again, the workhorse of MR therapy are the mitral clips. The newest generation, I believe we're now in the 4th generation, are really extraordinarily effective. There's a 10-fold increase in use in the last 3 years. They are indicated for high-risk patients. There may be an indication creep. We're applying it to younger patients, but they're very safe. The mortality is extraordinarily low, so we know that. But if you look at the outcomes, and again, this is the issue of, and again, you're looking at outcomes, we might be comparing apples to oranges. Survival, in this case, this is mortality, varies tremendously with the original etiology of the mitral regurgitation. So the degenerative or structural MRs have a very low mortality at 1 year, about 14%. Whereas if you look at patients with ventricular dysfunction, the etiology is 3 to 4 times higher, right? So again, when you compare series, what patient populations were they treating? More importantly to me is, what are the hemodynamics that you're left after you do a mitral clip therapy? So if you look at the current data, this is data from a year ago, I would say you have an ideal outcome from a hemodynamic perspective after mitral clip therapy in about 39% of patients. And those are patients that have a residual degree of MR of 1+ or less, mean left atrial pressure of less than 15. 49% of patients have an intermediate outcome, meaning that they have either more than mild MR or persistent left atrial elevated pressures. And type 3, luckily, it's only 11% of patients have a poor outcome. They have both residual elevated left atrial pressures and more MR. So if you look at survival curves, as the hemodynamics deteriorate from an excellent outcome to a poor outcome, there is significant mortality. You see that by the end of 1 year, the mortality for somebody who had a poor hemodynamic outcome is about 30 to 40%. But even in the best category, which is in the bar graph above, and you take the ideal, which is type 1, you have over half the patient that have a minimal improvement in New York Heart Association class, or die or have heart failure. So this is the ideal hemodynamic outcomes. So hemodynamic outcomes do impact survival, and perhaps we're treating people kind of late in the course of this pathology, and that might be the other variable here. But we know that if you do surgery after a failed clip, you can't repair those valves currently. We're working on it, but usually they will result in a mitral valve replacement. Once you have a clip in place, it's so adherent that it's hard to remove the clip and repair it. And again, the overall incidence of patients we're seeing here is quite low. We are close to 1,000 clips that were applied at the University of Washington. And we are now at about 2,000 patients that we see with mitral clip failures, but I expect that this will increase as we do more. So we know that patients that come to surgery, and this was presented at TVT this past summer, the median risk of the patients that come to surgery after failed clip is more of an intermediate category. Maybe we don't operate in the super high risk ones, only 4%, and mostly for either residual recurrent MR or sometimes mitral stenosis. But there is a 4-fold increase in mortality if they go to surgery after they had a clip, as opposed to their baseline characteristics. So there is a price that we pay. I don't feel in our experience here that it's quite 4-fold, but it's significant. Usually we operate them, now they have hemolysis, they have MR, there are other things, or they've been in failure for a while. And so we should consider therapy earlier if they fail. Now, these are the latest catheter-based valve therapies that we have. The ones highlighted in the A, B, and C are the choices that we have here at the University of Washington. The SAPIEN 3 valve has an anchoring device for the mitral. The EVOQUE, we put one yesterday. They're experimental valves for tricuspid regurgitation, and we're about to do our first Intrepid patient in the next couple of months. But again, if you look at the mortality for patients who undergo transcatheter mitral valve replacement, you're talking about 10% procedural mortality across the country and a 40% fatality at 1 year. Again, perhaps we're dealing with a very sick patient population, so it's probably a combination of imperfect therapies and very long-standing comorbidities. And there are several characteristics that have to be overcome for transcatheter mitral valve replacement therapies. One is to fixation. You want to avoid the prosthesis from being dislodged. Jay had to deal with one of those situations just a couple of nights ago. So we can add anchoring devices, and the University of Washington has developed some of these. The Delaware and the Arctic devices were developed here, so to minimize the risk of device migration. There was a risk of paravalvular leak and hemolysis, which is significant because the mitral annulus, particularly if it's calcified, is not symmetrical. And there's a risk of LVOT obstruction. And again, we can treat it with either alcohol or laceration of the anterior leaflet mitral valve or electrified wires to do a myomectomy equivalent. But despite this, these procedures require very extensive procedural planning. So Jamie McCabe would spend hours planning for each one of those procedures. They're very demanding. Very few interventionalists can do these kind of procedures very well. And they require a tremendous amount of intensive procedural imaging. So I do not see how this can be scaled to centers other than centers like ours, because the imaging that's required is extraordinary. So in conclusion, the clinical risks and progression of MR, in my opinion, are underestimated because patients are still under-referred, or the diagnosis is made very late when they're decompensated and they had all those other complications that impact survival. Surgical mitral valve repair outcomes are excellent and improving. Catheter-based therapies are also very promising, and patients are very high risk or prohibitive risk for surgery. And we need to assess patients fully and consider earlier therapy to all their underlying pathologies. Of course, there is a critical role for the multidisciplinary valve team to assess and coordinate these patients. And so we have 3 such teams every week in the at UW assessing patients with different groups of surgeons and cardiologists. And I can tell you that we rarely disagree with which patient should have whatever therapy. I think our agreement rate is something on the order of 95+%. But we have to consider that we're planning for a lifelong management of valve disease. We can't just assume that we do one therapy and it will last for the patient's lifetime. So it's very important to think about long-term consequences. So I want to thank you for your attention, and I'm happy to take any questions.
That was great. Thank you very much for that really educational lecture.
Yes. Oh, sorry.
Fantastic talk. I learned so much. My question is about, you know, as a cardiologist, I feel like I've referred a lot more TAVR patients, you know, to the structural team, and that's because of availability of randomized trials. Can you comment about, is there equipoise to do such trials? And, you know, because the patients are out there, that's true. But, you know, now we have, you know, at least for functional MR, we have all these more and more heart failure medications. Are we sure that we're actually prolonging life or having patients have less symptoms? Can you comment about that? Thank you.
So we know that the data exists for patients. So we go back to data from 20 years ago. There's no question mitral valve repairs prolonged life, surgical mitral valve repairs. But if you look at the demographic that I showed you earlier, so 20% of the population is older than 65 years of age. Many patients between the age of 65 and 75 years of age are physiologically reasonably active and fit. So I don't think in those 66 million people or 6 million patients that have severe MR that all patients should go to surgery. Some patients have significant comorbidities. And you could see how I think that patients who are under the age of 75, and even we have operated on people in their 80s, if they're physiologically fit, and we think that they would tolerate surgery, and they have a significant survival expectation, which you can calculate, they should have therapy, because we know that just medical therapy does not really impact survival. Now, this is for structural MR. I don't know what the data is for functional MR. And it's logical that if you eliminate MR in patients with congestive failure, it'd be easier to manage them. They would have better quality of life. Whether or not that will translate into survival advantage, I don't know. However, I think that also has to do with late referral. Because by the time you get to that point, it may not matter. So I don't think that we have to recreate the entire data set, but this is why I think it's very difficult to interpret that data, the difference between, for example, the French trials and the American trials. How many people had secondary MR, and is the impact in secondary MR the same as that of structural MR? So that's why I think the diagnosis is so important. Okay, yeah.
We've broken down that 10% mortality rate after TMDR and understood why is it predominantly from LVOT obstruction, or are there other main causes?
Those are technical complications because they are such brittle patients. So the patients we did the other night that, had device migration, dialysis, severe MAC. If you take out the MAC population, they have so many other comorbidities. Patients with mitral annular calcium that's sort of end-stage disease of structural problems. And so those are technical issues. So again, it's the opposite issue that now in the trials, if you look at the mitral transcatheter therapies, they're selecting the very best patients. They can have this or that, the other thing. Those are the ideal patients for the therapy, right? So they hopefully would have a very low incidence of paraprocedural complications. What's disappointing is, like the CLIP data, that even though you have great hemodynamics, that such a large percentage of patients still die. I assume that that's from the underlying pathology or that we're treating very late.
Two questions from online, both from Dr. Otto.
Okay.
She points out that exercise-induced pulmonary hypertension is not an indication for mitral valve intervention in the current guidelines. So any comments on that? And she comments that left atrial appendage occlusion amputation is class 3 to be avoided in patients undergoing valve surgery who have not had atrial fibrillation. So any comments on either of those two?
So I would never disagree with Catherine.
Well, I'm giving you the
in public,
opportunity to disagree with
in
me.
public, but I think that again, there are a lot of groups, and the Europeans do suggest that, in patients where you're really on the fence and trying to decide they're moderate to severe, or they minimally symptomatic or asymptomatic, that there is some value for exercise testing, right? And I kind of also agree that if you exercise everybody with that degree of pathology, most people would have an increase in their pulmonary pressures. The left atrial appendage clipping, I disagree with. I think that it can be done. I'm not talking about at the time of surgery, it adds literally 1 minute. And the incidence of atrial fibrillation in patients that we do mitral valve surgery on in a postoperative period is 30%. And how many patients develop late atrial fibrillation? So I can do it with a $40 suture in 2 minutes or put a clip on in 1 minute. And why would we not do that rather than send somebody very late to the cath lab for a left atrial occlusion device? So I understand guidelines, but I think that in our experience, I'm so impressed by the number of patients that have atrial fibrillation even after successful surgery, inflammatory changes, electrolyte changes after surgery. And the question is, there is a discussion, an active discussion in our surgical group, whether or not that should be a routine in older patients. So I agree in younger patients, I wouldn't necessarily do that, but I would like to understand why people would have a reluctance to do it when you have a giant atrial appendage or smoke in the atrial appendage in the operating room. And what's the downside?
And any thoughts on why it is class 3 in the current guidelines?
I do not.
All right.
I'm sure
We'll leave that issue there. Another question from online. How do you interpret minimal or mild mitral regurgitation at discharge following a valve repair? And what's your expectations on how quickly or whether it will worsen over the next several years?
Well, I would let you guys tell me about that, but I think that if you have more than mild regurgitation in the operating room, I'd go back and try to fix it. Because if you start with MR at the time of this year, even at the time, again, with surgery, we try to load the ventricle. We really want to test it. I would consider that an unsatisfactory repair. If I tested it before I came off bypass and patient had mitral regurgitation, I do more treatments in that sequential palette that we have for therapies before leaving, because I do think that if you start with mild MR, it would beget more MR later on. Now, there was also in an era where we didn't have future transcatheter therapies. So, maybe we can be a bit more liberal with it, but I think that would be a mistake. I think we can achieve those repair rates consistently in the vast majority of patients.
Any significance to trivial, what we sometimes call trivial MR?
No, at this point, at the best of circumstances, we want to see mild or trace MR. So anything more than that would be what I would consider a B outcome. Yes.
Thank you for a great talk. And it's particularly neat to see the data from you and sort of the program over 25 years. It's hard to improve on a 0% mortality rate that you achieve, but I'm curious with taking patients sort of for earlier intervention and trying to kind of continue to improve the program. Do you all focus a lot on, is there an increased focus on like rehabilitation of patients for surgery and kind of trying to optimize when you have time, patients are asymptomatic, but have the indication, do you put more emphasis on that in the outpatient sort of getting patients ready for more successful?
Well, we do that in all patients. So it's really interesting. It's a very good question. Actually, the patients that have the greatest increase in physical fitness are usually the healthiest patients. But in sick patients, even a mild increment in physical fitness, just from sitting to standing and walking across a room, that's the biggest improvement in survival you can have. So the sickest, most debilitated patients have the smallest increment in physical fitness and the biggest survival benefit. So I think you're right. We have to really emphasize those patients. Currently, most of those patients don't even come to surgical attention, probably correctly so. They would go to catheter-based therapies.
Sort of discouraged by the fact that if you place a clip, that it causes problems for you with the later surgical procedure. I'm sort of interested in how often, if ever, you see a patient that's considered too sick for surgery, gets the clip, improves to the point that they're now surgical patients. Is that even on the table in light of what you said about clips negate the benefits?
So, yeah, we see this rarely. If you look at the overall incidence, since we're close to have treated 1,000 patients with clips at the University of Washington, and currently the number of patients that go to the operating room after a failed clip, maybe it's a selection bias, I just don't know what the denominator is less than 1%, right? So if somebody was in cardiogenic shock, just like acute MI and a stent, and somebody put a clip in and you stabilize the patient, I think that's an amazing thing. And so then we can deal with that later. So it's usually patients who are elderly that we really, for some reason, elected not to do surgery. Maybe they're late 70s or 80s with some other comorbidities. But in that patient category, if we do chordal preservation, you do a valve replacement, it's not such a terrible thing. Then you can still preserve physiology with chordal preservation of biprosthetic valve. So I agree with you. That's a binary decision. If you go to a clip, that could potentially decrease the opportunity to repair the patient. However, on the other side of it, we're starting to work harder on seeing whether or not we can remove the clip and still repair the valve. But again, the patients I give, the last 2 dozen that I operated on, typically they need a mitral valve done because, now they have 3 or 4 clips, not 1 or 2. They have tricuspid regurgitation, and then now have an iatrogenic ASD. So you ending up with a 2-valve operation, left atrial appendage clipping, probably a pacemaker. And so, and now you're dealing with somebody with hemolysis on top of it, the chronic renal or acute or chronic renal insufficiency. So it's a complicated problem. Not as common as I thought. Same thing on the TAVR side. I'll come back to you, Laura, in a second. The same on the TAVR side, we were really concerned that we will never be able to take a TAVR prosthesis out without replacing the root. We're getting better at it. So it doesn't completely exclude. That's what I'm saying. There's an opportunity for improvement because in those patients that fail clips, we're going with the mindset of, we're going to try to salvage this situation and minimize the risk. Again, when you're doing a repair, you have to be willing to, if the repair is not perfect and you spend an hour in a cross clamp, take it all down and replace the valve because you have to have a good outcome at the end. So it's a calculus. It's based on experience, patient characteristics. But that's why I think that somebody who's young, you should think long and hard before you're putting a clip in.
Does the duration that the clip is in place affect the repairability of surgery? In other words, you wait.
Yes. The answer is yes, because there's more and more scarring. That thing looks like an alligator clip. And the more scarring there is, the more unlikely you are to repair it. Yes, Lauren.
Last question.
Thank you. So in the aortic stenosis world, there are guidelines, younger than 65 surgery, older than 80 TAVR. In the middle, there's some gray zone. Here, I think our institutional experiences, roughly around 70 and above, we tend to lean towards TAVR. What's your approach to the decision as to repair or replace in different age categories? You get a 77-year-old with, primary MR. How do you approach this?
Well, we're at the University of Washington. We're pushing the limits there because I think that in my mind, it's a very good question, Laura. In my mind, it has to do with going in with an idea of what is the life expectancy for that individual. And you've actually done a lot of work on that and shown that you can actually calculate it for an individual. So if I think the patient has a life expectancy of 10 years, I would try to repair it because I think even in elderly patients, there is a significant benefit for repair rather than a replacement. So if it's just mitral valve or mitral tricuspid, we would typically try to repair that valve. And I would say up to the mid-70s, if not later. And if somebody is physically fit and no other comorbidities, I would have tremendous amount of enthusiasm for that. So it's not age specific as much as what patient are we dealing with. At least that's my practice, our practice, because you're there with me doing all those things.
Let's thank Dr. Medea.
Yeah, please.
Back here next week, same time, same place. Thank you.
All right, thank you, guys.